Hello? Okay, it's okay. Dr. Muluka?
Yes.
Yeah,
Hello.
I think we are now fine. I think we are now
Okay.
fine.
We're now
Joshua,
fine.
you can go
Okay.
ahead.
Thank you so much. Good afternoon, good evening, everyone. Thank you for joining this early. Even though we are quite behind the schedule, we were supposed to start at 6 p.m. So this is our 14th session that is going to be led by Dr. Muluka, who is a consultant, obstetrician, and a gynecologist. And I want to give time without taking a lot of time to her so that she can take us through the discussion today. Please feel most welcome, Dr. Muluka.
Thank you, Joshua. Thank you very much. And thank you to everyone who has joined the session. Today evening, we're going to be talking about something that's very common, cesarean sections. And even as I was preparing for this talk, it was a bit of a battle to decide what exactly to talk about. And so I had asked Katile to share some of the questions that this group specifically, because cesarean sections is such a wide topic, and depending on the audience, then there are different things that you'd have to touch on. So the presentation is not that long. So we are lucky because I know we're running late, and I'm hoping that we'll be done by 7 p.m. So I'll go through the presentation, and then we will go through some of the questions that you had raised. And then in case there are any other questions, then we can have maybe a last 15-minute section whereby you can put those in the chat session. So I hope that's okay. I hope you can all see my screen. Kindly confirm, Joshua, that my screen can be seen. Hello? Hello? Can you hear me?
Yes, Doctor, we can see your screen.
Oh, okay, fantastic. Yeah. Okay, so we'll just get started. And so this is the order of our lecture. We're going to have a brief introduction and look at the history of cesarean sections. And then one thing that really came up, most people were wondering who requires a cesarean section. So we're going to talk about what the indications for cesarean section are, and then closely followed by what are some of the risks that this procedure poses. And then, as I said, we'll take the questions. I'll start with the questions that were already pre-sent to me. And then if there are any additional ones, we'll go through those. So what is a cesarean section? Basically, it's one of the most common surgical operations that's performed on women. And it is a procedure that is used to deliver a baby abdominally. So as opposed to a baby being delivered vaginally, they're coming through the abdomen. So an incision is used on the abdomen, and we go through a number of layers. So we go through the skin, and then there's usually the fat that is underneath that. And we get to the level of the muscles, which we put aside. And then we get to what immediately covers the uterus, known as the peritoneum. And finally, the uterus. And we put a cut through that, and we get the baby out. So it's an increasingly common mode of delivery. Across the world, it's attributed to account for about 15% of the deliveries. So as you can see in the image, they're saying it's a natural method of a natural event. The natural event being the birth of a child, yeah? And so we are going through it in a different route. So a bit of history. When was the first cesarean section? In fact, the word cesarean, it's thought to have come from Julius Caesar. Legend has it that he was born by cesarean section, but we don't really have true records of that. It's just thought that in about 100 BC, he was born through a CS. But the first recordings of a CS were in the 1500s by a gentleman known as Jacob, who reportedly performed the first cesarean section on his wife. And the lady actually survived, and even the child who was born through the CS survived. And she later went ahead to have more children through natural methods, however. So in the mid 1800s, around 1846, there's a gentleman known as Morton who brought in ether as a method of anesthesia. So this was revolutionary for the cesarean section, because before that, they did not have like proper methods of pain control. So when ether was introduced, then at least it was something that was tolerable, because I mean, the procedure was now being done in a painless manner, okay? And then in 1860s, then we're introduced to now antiseptic measures, whereby you're able to carry out the procedure in a safe manner, limiting the risks of infection to the lady. Then when we got to 1900, what is known as the bikini cut or the Fanning Stale incision was introduced. And all these things are discoveries which have made the CS a better experience for the ladies and even for the babies. And once we got to 1928, then there was the introduction of antibiotics. Penicillin was discovered by a gentleman known as Fleming. So in this image, what we're trying to show is a CS that was reported to have taken place in Uganda in 1879. And as you can see, the instruments being used are crude. There doesn't seem to be any anesthesia. The lady is being held down by people so that she does not, get away from the procedure. But here we are in the year 2021. I hope the image is not too graphic. And this is how you can see everything. We are adhering to proper antiseptic measures. We're wearing gloves. Babies being born in a what you can call quote unquote sterile environment. So really the CS has come a long way, right? And so this is just to show us what exactly happens and or where do we do these skin incisions. I want our attention to be drawn to the image on the left, so I'm making it a bit bigger. And so this will also answer some of the questions that came through from the audience, the type of CS incisions. And you can see the lowest, that's the Fanning Stale, the one that we've talked about, that was introduced in the 1900s. And then you can see there's what we call the Joel Cohen incision, which is increasingly the more common incision that's used for CS now. And previously we used to use what was called a midline vertical incision. So you can see it comes down from just under the belly button, the umbilicus, coming down just to above the pubis. So those are the type of CS incisions that are commonly utilized. Now, when we're thinking about a cesarean section, which is abbreviated as CS, we always have to ask ourselves who requires a CS. And I think many of the audience were asking, how does a lady know that she needs to go for a CS? So basically, a cesarean section is, the decision is usually made by the doctor who is seeing you, and there are certain indications. So it could be an issue with the mother, or it could be an issue with the baby. So once you're in labor, there's a natural way that we expect labor to progress. A lady should be able to move from being not dilated at all to 10 centimeters dilated in a certain specified fashion. And normally we use tools such as Patograph to monitor this. Now, if a lady is not progressing as we are anticipating, okay, and we have intervened with the right measures, to try and see if the labor can progress, but she's not able to progress in the normal way, then we make a diagnosis of failure to progress in labor, or what is called labor dystocia. And at this point, we then can prescribe for a cesarean section. Now, there are some cases whereby a lady is told that njia ilikuwa ndogo, or basically it was an inadequate pelvis. So this usually we see it in cases whereby maybe the baby is a big baby and so cannot be able to pass through the mother's pelvis. Other times when we talk of inadequate pelvises, we could be talking about maybe a teenage pregnancy. So a lady who got pregnant when maybe her anatomy wasn't fully formed. We've seen young girls getting pregnant, and so they can have what you call an inadequate pelvis. And so the only or the better way to get the baby out would be through the abdomen, the CS. Okay. Now, there's also indications when a lady has had prior surgery of the uterus. For example, a myomectomy, which is when we are removing fibroids. And so this usually have caused a loss of integrity in the uterus because you have cut through that uterus muscle to remove the fibroids. So usually in such cases, you'd find if a lady has had prior surgery for removal of fibroids, she's usually advised if she then falls pregnant, the best method for her to deliver by is cesarean section so as to not cause strain on the already imperfect uterine tissue because it's already been cut before. So there's an increased risk of it tearing or rupturing if at all the lady was to go through normal labor. Then we have cases whereby a cesarean section is indicated when there is a failed induction of labor. Now, induction of labor is a process whereby we try to get a lady to go into labor using medical methods. So maybe labor has not come in naturally, and sometimes it's that she's past her due dates, what sometimes is known as postdatism, and you want to get this lady to go into labor. And so you start the induction process. Normally it's drugs that are used. And even after putting her on those drugs for the required amount of time, she does not go into labor. Then that is someone who you have to think of an alternative way to deliver that baby. And that's where the cesarean section then comes in. Now, the next one is previous cesarean delivery. And this is not mandatory for all ladies. That if you've delivered via cesarean section, then your next delivery must be a cesarean section. But it is one of the indications, especially if the reason for the first cesarean section is something that repeats itself. For example, if a lady's pelvis is just really, really small, then you know that that's a lady who maybe cannot be able to deliver vaginally, even if you were to try. So usually it's a function of what are the factors that cause the lady to have the CS in the first case, and then also to see if she is a good candidate for trial of vaginal birth after cesarean section. So this may be one of the indications. There are also some ladies who, once they're cancelled on the risks of trying vaginal birth after cesarean section, they're not willing to try it. And so that they end up in this list of people who require cesarean section. Now, we have women who sometimes go through labor, and normally it's a prolonged labor where we experience obstruction, the baby is taking long to come down, and we end up having abnormal communications between the vagina and the bladder, what is known as a fistula. So if a lady has ever had a pregnancy where that was an occurrence, we call it a vesicovaginal fistula. Basically, it's just direct communication between the vagina and the bladder. So instead of urine coming out through the usual route, the urine is leaking through the vagina as a complication of vaginal birth. Now, once you have had such a complication and had it repaired, this is not a lady that you would want to go through natural labor and deliver vaginally again, because she's at risk of this recurring. So that would be another maternal indication for cesarean section. Now we can look at some of the fetal indications, and some of the ones that commonly occur are if a baby has an abnormal fetal heart rate. So during labor, we usually monitor the baby's heart rate, and it tells us about the baby's condition. So when we have a state whereby the baby's heart rate is not falling within the normal ranges, or it's not responding the way we expect it to respond to certain stimulation, then we call that a non-reassuring fetal status, and it's usually one of the commonest indications from the baby for going for a cesarean section, okay? And then we can also have babies who are not in the correct presentation, in that they aren't coming in with their heads, because for you to have a safe vaginal delivery, ideally the baby is supposed to be, the head is what should be the leading part, and specifically what we call the vertex. So if the baby is not well presented in the pelvis, or if they're coming with the arm or it's the foot that's coming out, then you may find that that's an indication for going for cesarean section. Now, there's also situations whereby we have what we call multiple gestations, whereby a lady is pregnant with more than one fetus. So we can have twins, triplets, quadruplets. Now, it's not a standard rule that twins must be delivered via CS, There are some who have delivered vaginally. However, it has increasingly become an indication for cesarean section, especially in cases whereby the first twin is not coming down with the head, what we call cephalic. Then we end up going for cesarean section in that case. So this basically is a broad guideline as to what would then prompt a doctor to then prescribe for a lady to go for cesarean section. It's really important for ladies to be informed about these conditions so that even prior to going into labor, you are mentally prepared that in case this and this happens, then I may end up not delivering vaginally. It may end up being a cesarean section. So those are some of the things to note. Now, those just a mention on the types of cesarean sections. We can basically group this in terms of timing. That means when is the cesarean section being done? Is it a planned cesarean section or is it not planned? So that's where we have what we call emergency cesarean section, and we also have what's called an elective cesarean section. Now, an emergency cesarean section, as the name indicates, no one had planned for it. We did not know that this lady was going to require a cesarean section. Basically, maybe she was in labor and things seemed to be going well. And then at some point, there was something that occurred that necessitated us to take her for a CS. And that's why it's called an emergency cesarean section. And most of the things that we have talked about would likely fall under emergency cesarean section, things that then occur during the labor phase. Now, the other things that may still fall under emergency that may occur without labor, maybe if a lady is excessively bleeding prior to going into labor, or even if it's in labor, then she may end up as an emergency cesarean section. Now, the word elective is basically used to mean a planned cesarean section. And more often than not, these are cesarean sections that you do not need to rush in because there's no immediate danger to either the mother or the baby. With the emergency, there's an imminent danger to either mother or baby, and that's why you're rushing into theater. So with elective, things are not, there's no immediate danger, but basically you've decided that the safest route for delivery for that baby would be a cesarean section. And this could be the cases whereby maybe a lady has delivered previously via CS. She's had one baby or two babies via CS, and she wants to have another baby. And so that would be a planned cesarean section. And usually we tend to plan the elective cesarean sections a week before the due date. So at around 39 weeks, that's when we do what we call the elective cesarean sections. Now, another way of classifying cesarean sections is whether it's a primary cesarean section or a repeat cesarean section. And basically this just means for primary, it means that it is it's our first delivery and it's been planned as a cesarean section. So it's basically the first cesarean section, okay? And then a repeat cesarean section is, as we've said, someone who's already been delivered via CS previously and is coming to deliver again. And so we call that repeat cesarean section. Now, when we're talking about cesarean sections in terms of the uterine incision, because that's another way of classifying them, basically we are talking about where the cut is being made on the uterus. And normally the safest route of approaching the uterus is via a lower cut on the uterine wall. But sometimes you can do what's called a classical cut, which is a longitudinal cut, but we tend to go for the lower uterine cut because that's the safest, because this segment of the uterus usually is much thinner and heals much better. So this is just to demonstrate what we're talking about. So there you can see that's the baby in the uterus, and the part that's indicated as the lower segment incision, that tends to be where we cut on the uterus, okay? There's what's called the classical incision, and you can see that's going all the way from the upper part, what we call the fundus of the uterus, to the lower uterine segment. And so you can see you're cutting through a bigger chunk of tissue, and usually it's quite thick. So you may have more bleeding with that. And even in terms of risk of rupturing in a future pregnancy, it's at a higher risk. There's what they call the DeLees incision. It's just kind of like a modification of the classical incision without going all the way up. But this would maybe be used for a very small baby, a preterm baby, likely, because more often than not, the incision you're making has to be about 10 centimeters for the baby to come out. And the deal is the incision is much smaller than that. So now we're going to talk about what are the risks of a cesarean section. This really came out in most of the questions that were asked. And so I'm going to try and address them comprehensively in this slide. So during cesarean section, cesarean section is definitely at an increased risk than having a normal vaginal birth. And this would be the reasons why, because there's risk of injury to a number of organs during the procedure. The bladder usually lies just on top of the lower uterine segment, just adjacent to it. And so usually there's risk of cutting through the bladder in some cases. And so consider that about 1 in 3 women out of 1,000 women who have cesarean section end up with a bladder injury. Now, there's also what we call the ureter, which is what brings in urine from the kidneys. So it's a tube-like structure. And so for that, there's also risk of injury to the ureter, but it's less common than the bladder, because you can see only 3 in 10,000 women end up with this kind of injury. Then there's usually the gut or the intestines, what we're calling here the bowel. And they usually are, because you are in the abdominal cavity, there can be a risk of you also injuring the bowel. And so that risk is very small, less than 1 lady out of 1,000 women suffer from such an injury, okay? Now, the other things that can occur after you've done the cesarean section, and the commonest complication after CS is wound infection. And to this end, that's why people nowadays we give antibiotics routinely after we've done the CS. Previously, there was the thinking that if you're doing an elective cesarean section, you may not need to give antibiotics, but by and large, most people are moving more and more towards giving antibiotics, whether it's after an elective cesarean section or an emergency cesarean section. And so you can see the rates of wound infection there, about 2% if you give antibiotics, so they may still get a wound infection, and about 7% if they're not given any antibiotics. Now, during the CS, there's also a risk to the baby, because as you can see, the baby is delivered through a cut on the uterine wall. Now, this cut, if someone is very aggressive, sometimes you can get injuries on the baby. You may come out with a cut on the head, yeah? So there's about a 2% risk of that. And then the bleeding during cesarean delivery is definitely more than that is encountered in a vaginal delivery, because obviously you're cutting through tissue, and when you cut through tissue, tissue bleeds. So there are some cases whereby you end up with excessive bleeding during the procedure, and women then require to be transfused blood. And this shows that about 5 out of 1,000 women end up in this category. Now, there's also sometimes when the bleeding gets too much, we may have to do what is called an emergency hysterectomy, which is removal of the uterus. So this, usually the risk of that is about 8 women out of 1,000 may end up in that category. Then the others who may end up being admitted to HDU or ICU for observation, about 9 out of 1,000 women who undergo a cesarean section. And then what we call thromboembolic disease, which is basically the formation of a blood clot, usually in the lower limbs, which may then travel up to the chest, whereby it can cause what we call an embolus. And there's a risk of about 4 to 16 out of 10,000 women developing that after they've gone for cesarean section, which is way higher than that for women who have not undergone the procedure. Then there's also a risk of death, women who have undergone CS. It's 1 out of 12,000 women. So these are very significant risks, and that's why a cesarean section is not a procedure to be taken lightly, because you may go in and everything goes well, but as we counsel women for CS, we have to counsel them about these potential risks that they need to know as you go in. This is what it basically could look like. Okay, so these are the risks at CS or immediately after the CS. There's some risks or complications which can occur in future pregnancies if a lady has had a cesarean section and she then may want to try for a vaginal birth after a cesarean section. There's usually an increased risk of uterine rupture. And what this basically means is that the scar at the point where you had cut to have the baby come out could give way. And this usually tends to happen when it's under stress, which is during labor. So if a lady is a good candidate for a vaginal birth after cesarean section, and she is willing to try for that, then we always have to counsel them that there is a risk that 2 to 7 of the women who try, out of 1,000 women who try to deliver vaginally, may end up with a uterine rupture. And in these scenarios, unfortunately, most of the time we lose the babies. And then we have to go and see if we can salvage the uterus. That means you have to try and repair that place of rupture. In some cases, if you're not able to repair where the rupture happened, then you end up having to do a hysterectomy to remove the uterus. Now, there's also an increased risk of having a stillbirth in future pregnancies, about 1 to 4 out of 1,000 women. Then the last one is an increased risk of abnormal placental location. Basically, the placenta now comes in the next subsequent pregnancy. It lies close to the cervix, which is a condition we call placenta previa. And that can then now bring issues in that pregnancy, such as bleeding during the pregnancy. And obviously now it ends up being an indication for another cesarean delivery. So I hope we are together up to there. So this is basically to just try and answer one of the questions that someone asked, whether a lady can opt to just have a cesarean section. You can see the doctor is telling her, so you're due on the 17th, that's her due date. But she says that she's all booked, she seems to be very busy, and she's opting to go for a cesarean section on the 4th, okay? Even discussing in terms of time, how does 1 p.m. sound? So what happens in cesarean deliveries upon maternal requests? This is an ethical issue because obviously the mother's values, dignity, her fears and wishes should be respected. However, the doctor's clinical decisions should not be micromanaged by patients. For example, if a patient is in labor and the labor pains her so much and she just feels that she cannot take it anymore, she says, "Daktari, me just take me for cesarean section." Now, that is not ideally what should happen. So we're supposed to address whatever the concern is. If, for example, it's pain, that the lady is having very severe pain, then we try and control the pain. There are pain control measures that we can use. There could be drugs, it could be the gas, or it could even offer an epidural to try and see if at least that would settle her to give her the best chance of having a vaginal delivery. However, if that fails, or if you're in a setup where you may not be able to offer any of those methods, then you have to ensure that this lady has given what we call informed consent. She has fully understood the risks that we have discussed above. And as you saw, it was quite a list, that those are the potential risks of having a CS delivery. And especially given that for her, you're going in without an adequate indication. There's no imminent issue on the mother or on the baby. And then if the doctor is then willing to go ahead, then the cesarean section may be carried out at that point. However, if in some cases you may find that the doctor caring for the lady may not be comfortable just going in for a CS on maternal request, then usually at that point, it's time to call in a second opinion, maybe another gynae who may be able to carry out the procedure upon maternal request. So that was what I basically covered, because I felt at this level that was mainly what would be of interest. But I want us to quickly now look at some of the questions that you asked. I don't know if you can see my screen. Kindly, Joshua or Katile, confirm to me that you can see the second screen I'm sharing.
Yes, we can see the second screen.
Okay, thank you. So I think we'll just take it from the top, and whatever I have answered, I'll just allude to it. If I have not answered, then we'll try go through it. And in the meantime, I think anyone else who may feel that there's any other clarifications may start typing in the chat so that we try and see whether we can at least address whatever other concerns may be there that may not be in these questions. So how can one prevent a CS, and can age have effects on delivery? If so, what age is someone supposed to have a safe pregnancy and delivery? So how can one prevent a CS? The best way to prevent a cesarean section, it actually falls on the entire team that's managing a lady during labor, is to try and prevent the first cesarean section. So most guidelines nowadays are trying to avoid what we call the primary cesarean section, because once you're able to avoid that, then you're able to avoid all these risks that then come with cesarean section. So number one is to proper management of labor, to be able to give ladies adequate time. Nowadays, we're moving more towards calling active phase of labor when a lady has reached 6 centimeters, so that we are not hurrying her, because previously we used to say a lady is in active labor when she was 4 centimeters dilated. Now with the movement to 6 centimeters, it means that we're giving ladies more time to go through labor before we actually come up with a diagnosis of poor progress of labor. So in that way, we are at least having less cases of primary cesarean sections because of labor dystocia. Then the other thing is to just offer a lady good support during labor. So most hospitals prior to COVID had started picking that up in the private sector. You'd find that you're allowed to have a labor partner who at least would be there with you during the labor, can help to rub your back. And it's been shown that when women are supported during this time of labor, then they tend to have more tolerance even for the pain, and we end up having more vaginal deliveries as opposed to cesarean sections. Other things that, of course, we have mentioned are good and adequate pain control during labor, so that women don't feel like they just need to give up and go for what the alternative is. Now, also doing things like some of the Lamaze classes, which have been introduced in some of the hospitals, help you to prepare mentally. It's mentioned that if ladies are more mentally prepared for labor, then they're able to tolerate it better. So showing the Lamaze classes have been shown that they help women and show them how they can do breathing exercises and even some pelvic exercises that can basically assist even at the time of delivery, you're able to then bear down properly. Now, the next question is, what age is someone, can age have effects on delivery? Yes, it can. As we had mentioned, if one is too young, if you're having a teenager, then you may end up in the cesarean section group because you'd be having what is called a contracted or inadequate pelvis. So what age is someone supposed to have a safe pregnancy and delivery? Usually after the age of 21 years, you are shown to have a fully mature pelvis that, should be adequate for delivery. And so any point after that, most ladies are able to deliver, but we've seen ladies who are even younger than that able to deliver vaginally. So it's actually just a function of one's pelvis in some of these cases. Now, the next question is, why is it that after CS, there's too much back pain, backache after a small work? Why is the scar so itchy? So I think I'll start with that one. Why is there so much back pain after a CS? Now, when we do cesarean sections, nowadays we mainly use, for anesthesia, we use what is called the spinal anesthesia. And what happens is that basically a needle is introduced into the spinal space, and that's where the drug that now numbs a lady is then inserted. Now, with this method, sometimes the muscles that are surrounding that area go into what's called a spasm. They're just contracting continuously. And these spasms have been shown in some ladies to last for weeks or even a couple of months. That could be one of the causes that may be specific to cesarean section. However, most ladies after delivering, whether via vaginal method or cesarean section, may have some form of back pain. And this is just because the back tends to, during pregnancy, you do gain weight, which is, it takes time to shed that weight, even post-delivery. And so because of this excessive weight, then sometimes you may have now this back pain. Then there's also the strain on the back, because once you deliver the baby, then you find that you end up doing a lot for the baby. You're changing the baby, you're picking up the baby, and all that also causes muscular strain to the back. So that could account for part of why those pains are there. The other thing is that even with the vaginal delivery and CS, that your body usually is preparing for you to deliver naturally. And so there are certain hormones that are produced. One is known as relaxin, which is to help basically the muscles and your tissues, and the tissues that hold the muscles to the bones, they're called ligaments, to kind of relax, basically, so that you're able to deliver normally vaginally. So this hormone is produced regardless of whether you deliver via CS or vaginally. Now, if your muscles have become basically what we call lax or loose, then any small strain on your back can really result in a lot of back pain. So the best thing usually is advised to ensure that you have good posture post-delivery, especially when you're handling the baby. And if the pain is very severe, then one may need to be seen by a physiotherapist to have some physiotherapy sessions that could assist with that. Okay. Now, the next question is, why is the scar so itchy? Sometimes, why is the scar so itchy sometimes? The scar, usually during the phases of healing, there are certain times that you will have the scar becoming itchy, and that is normal because it's part of the scar healing process. However, different people scar differently. The people who may form what we call a hypertrophic scar, ideally when the scar is fully healed, it should just be a thin line. But when you have a hypertrophic scar, you end up having a scar that is thick, that you can actually touch and feel it. So those scars tend to have active tissue in them, and they tend to be itchy, especially times when it's cold or as extremes of weather, when it's extremely hot or it's extremely cold. And then there are other people who also scar and form what's called keloids. Now, if you form a keloid, then that can also cause, you can have the same thing as the hypertrophic scar with the excessive itchiness. So it's important for one to know and to look at the scar. If you're having excessive itchiness, you may need to see a doctor. And sometimes there's, natural methods to deal with that itchiness. Some people advise using cold packs over it, like just taking some ice and putting over the scar at the time when you're feeling the excessive itchiness. Others, there are some creams that you can be given by your doctor. So you could either see the gynae or you could go and see a dermatologist who can then help, especially in the cases of the keloids, which are very, very thick scars that are above even the scar line. It's like a big bump that forms. So depending on how one heals, then they could have this issue of itchiness. Now, what are the reasons for constipation after a CS? The reasons for constipation, usually it's mainly the drugs, because normally the drugs that you're given when you're in theater, and then there's also the pain medication that we use afterwards. And these drugs fall into a class of groups known as opioids. And they're very notorious for slowing down digestion and just causing one to get a lot of constipation. However, some women suffer more from it than others. And so usually when they're prescribed, most of the time you'll find that we also prescribe them with something to help the stool to become soft. So it's important also as we counsel ladies, even as they go home, to tell them that in case the constipation is too much, then they may need to come back and get some drugs for that. But there's also a function of diet in this. So usually after one has just had a CS, you may not want to eat certain, because people now just naturally think that as long as you're eating vegetables, then they are good for the digestion, but there are some that make the stool bulky. And so those ones may actually worsen the constipation. So it's best to speak to the gynae before you discharge and just find out what you should eat and what you should not eat in the first few weeks, as it takes time for those drugs, the opioids, to come out of your system. Now, after how long after the first CS can one have a normal delivery? Now, this question is usually a very difficult one to answer, because previously it used to be thought that one should wait for 2 years after having a cesarean section before they can then go ahead and have another delivery, which may be vaginal. However, studies have now shown that the CS wound, the one that is on the uterus, because we talked about it, we said we go through the abdominal wall, and then the most important wound is the one that is on the uterus. It's been shown that that uterine wound usually heals after 3 months. Yeah, so that's actually 12 weeks. The integrity of that wound is good. So there's people who, from those research, they say as long as the lady has stayed 3 months before she conceived, and then she can be able to try for a vaginal birth. But most people are still a bit cautious and still use the 2-year mark as a time to say that now maybe you could try for our normal delivery. So what are the types of cesarean sections? I think we had covered that during the talk. And how long do cesarean sections last? The period of time that you take to do this operation really depends. It depends on the surgeon. It depends also on the patient factors, because the time that you take to do this procedure on a lady whose BMI is high, who let's say is obese, versus a lady who has normal or low BMI wouldn't be the same, because you are encountering more tissue. So that would really depend. And then also to depend on whether it's a fast cesarean section or if it's a lady who's had previous cesarean sections. And so you're dealing with maybe having to dissect scar tissue before you get to the uterus. So by and large, I'd say about an hour would be the normal time, but that would really depend on how the procedure goes. If there are any challenges that occur during the procedure, then that may then cause the procedure to take longer. Now, what are the procedures and risks of cesarean sections? We have covered that. And how do doctors know if a person needs cesarean? We talked about the indications, both maternal and fetal. Is CS riskier than giving birth normal? Yes, it is. And I think we've gone through all those risks. The things that we saw risk at CS, they are not there for a vaginal birth. Or even if they're there, they are way reduced, especially like now the ones for infection. That one is still there. The risk of having a clot or an embolus, that one is still there, but still significantly reduced than for cesarean section. Now, how will one know that it's time they should request for a cesarean section? Ideally, the patient is not the one to request for a cesarean section. But as we have discussed the different things that can be the indications, and if a patient is enlightened, then you can have that discussion with your gynecologist. At that time, you'll be able to be on the same page. Now, for cesarean mothers, how many babies can they have? So this is also another question that is usually quite contentious, because different schools have different thoughts. There are people who used to cap the number of babies that one may have at 3, but we've seen women delivering even up to 5 babies via cesarean section. So there is no one specific answer for this question, but most schools of thought say that if you've had 4 children via CS, then it's time to think about maybe not having any more, because the risks of cesarean section increase the more times you have the procedure. So you keep forming scar tissue, and so risk of injury of organs is significantly increased. Risk of rupture of the uterus is also significantly increased. So by and large, you find most of the time when you've had 3 children, 4 children via CS, then you'll be having a conversation with the gynecologist about maybe thinking about stopping at that point. However, we have seen women deliver more children via cesarean section. So there's no one specific answer. The most important thing is to know that the more times you go for cesarean section, then the higher the risk of injuries to you. So that's, I think, would be the best answer for that. Right, so where are we? For cesarean mothers, how many babies can they have? We'll answer that. Can a cesarean mother give birth normally in her future births? Yes, we've talked about that. It is possible, depending on what the indication for the first cesarean section was. If it's something that is not repeating itself and a lady is a good candidate, that means number one, she has to be willing to try the labor after vaginal birth, and she has to be willing to also admit at the point whereby the trial of vaginal birth after cesarean has failed. And then the other things that we look at, we look at whether the lady goes into labor naturally, because that's one of the factors that has to occur. You cannot do typically induction of labor in these ladies. Then it's usually after only one prior cesarean delivery that you can be allowed to try to have a vaginal birth after cesarean section. If you've had more than one cesarean delivery, so 2 and above, then usually you're not a good candidate. Then also another factor that we look at is the weight of the baby, which is usually estimated by an ultrasound. So usually the baby needs to be less than 3.5 kgs for us to say that we can try for a vaginal birth. So yeah, those things, those criteria need to be met prior to the gynae giving the go-ahead for the procedure. Now, how long does it take for the wound to heal? So I think we've answered this. In terms of wound healing, most people usually just talk about the wound on the abdomen. And that one, usually the first cut, the one that's on the abdomen, by the time it's 2 weeks in, you'll find that the wound is healed, it's dry. And in terms of its integrity. However, the healing of wounds takes place in stages. So the cesarean wound, the integrity of that wound would be good by the time 3 months after the procedure. So that's 12 weeks. But still, you find that wound healing takes place in stages. And so some of the stages of wound healing can take even up to 1 year. So that's why you can find that sometimes some women may still experience some pain over the wound because there's still active tissue in that wound. So by and large, the best answer for this is that it takes 3 months for the wound on the uterus to heal. Okay, but for the whole process of the wound to try and get back to normal tissue, then that could even take up to years in some people. How many times is cesarean delivery safe? I think we have answered that. And how long does one recover from cesarean delivery? Most people, by the time you're 2 weeks after the CS, you're able to carry out duties that do not involve heavy lifting. And by the time you're 3 months down the line after the CS, most people are back to normal, everyday work that they used to do. So that I think should answer that. Long-term risks and benefits of cesarean section. So I think we've talked about the risks. In terms of benefits of cesarean section, it's an adequate method to help in safe delivery for baby in times where we think there's a compromise, and also in times where the mother maybe is just not able to deliver vaginally, then it comes in as a good method for that. In terms of side effects, I think this we have covered when we talked about what are the risks that occur, and then what are the psychosocial outcomes following an emergency cesarean section. It's a good question because emergency cesarean section 1 is not prepared for it. And more often than not, when ladies go into labor, we are programmed to just be prepared for a vaginal delivery. Now, when you hear of an emergency cesarean section, then there's a lot of stigma that comes with cesarean section delivery, because there's people who sometimes you hear say things like, wewe hata ujui uchungu ya labor, you don't know what it's like to go through labor, or wewe hata ukuzaa, someone helped you to deliver. So there's all that stigma that comes with cesarean section, and some ladies end up feeling like less of women, so to speak, because they did not end up pushing, or they feel like they failed themselves, they failed their spouses, or they failed the society at large, because these are the expectations that people have of women. So you find that even when women, sometimes they're not really keen on disclosing that they delivered by a cesarean section. So there's a lot of stigma that is associated with CS deliveries. And there's also a lot of misconceptions that come with CS delivery, that you cannot deliver normally after a CS, for example, or that you can not have many children after having a CS. So those are some of the things that ladies who have cesarean sections have to deal with. And sometimes you even end up with postpartum depression. You know, you find ladies not bonding well with their babies just because they ended up having cesarean section, an emergency cesarean section especially. So these are ladies who usually need to at least have some form of counseling support and, you know, to understand the reason as to why the cesarean section had to be done, and that likely if that intervention was not utilized, then we would have a different scenario whereby you may not be having a baby, or even the mother may not be there. So I really like that question. Whoever asked that one, that's a very important thing that I think is not really addressed enough. Yeah. So what happens during a cesarean section? We have discussed that already, and how is cesarean section done? We've talked about that. The different incisions that are carried out. What are the benefits and dangers of it? I think we've answered that. Under what circumstances is CS advisable? That has been covered. After someone has gone through CS, how long must she take before engaging in sex? So good. This is a good question because it comes out a lot. Usually we would want you to be seen after your CS delivery. The first time you're seen is after 2 weeks. And the one is just basically for us to look at the wound to see how you're healing and how you're coping. Then usually we have another visit after 6 weeks. And at this point, when the doctor assesses, if we feel that the wound is fine, you seem not to be having pain, then we usually can give the go ahead to engage in sex. So by and large, it's 6 weeks. There's some people who have had sex previously before the 6 weeks and nothing has really happened, but for the safety, we usually advocate for 6 weeks. Now, does CS interfere with the normal functioning development of a child who is born through that process? No, it does not. In fact, it's said that if children could be asked which route they would want to choose for delivery, do they want to go through labor or do they just want a CS, they would choose the CS because labor is also strenuous on the baby. So it absolutely does not interfere with, it's not been shown to interfere with any functioning or development of these children. Is there a maximum number of CSs? I think we've answered that. Hello. Hello.
Yes.
I don't know if they can hear me.
We can hear you, Dr.
Okay, thank you. So I don't know if there are any other questions that I'm seeing there's something in the chat. Someone has mentioned that they underwent CS 3 times after the last one, have always experienced numbness of my lower limbs. What could be the problem? Now, normally when you undergo CS, it depends on the method of anesthesia, because this sounds more like an anesthetic related complication, because as spinal anesthesia is being given, then obviously there's always the nerves that are around that area, and if there's an injury to them, then you may find that you can have intermittent numbness. The thing is, most of the time this tends to go away with time because nerves tend to regenerate themselves, but it's something that warrants being assessed. It would be wise to be seen by a neurologist so that they can just do a full assessment to ensure that there's no other issue that could be going on. Is there any other question? Let's see. In the chat, someone has said, is Joel Cohen, type the bikini 1CS. Okay, so the bikini name came from the Fun and Stale. I think I'll go back to that slide. Let's see, where is it? So yes, so this, the bikini, people used to call it the Fun and Stale, the bikini incision. But yes, now we're moving more towards Joel Cohen incision because it's been shown to have less pain, better healing, and it's still a bikini cut because, I mean, if you were to wear a bikini, it would not be seen. So that would still suffice to be called a bikini incision. Then, is inducing a mother another cause of CS? Yes, it is. I think I had answered that before. If induction of labor fails, then the mother will go for a cesarean section. I think someone has even answered it, Ivana. Thank you. For how long should one get pregnant after CS? Really, this, again, by and large, there are no hard and fast rules. But as long as it's 3 months, as long as the baby is coming in even 3 months after the CS, you're safe. Okay, so we've seen ladies who have fallen pregnant even about 6 weeks after they've had a cesarean delivery, and they've gone ahead to just deliver the baby, carried the pregnancy well, and delivered. However, those ones end up going for a repeat cesarean section. So you can actually fall pregnant immediately if you do not use family planning. If you don't use contraceptives, then some people actually fall pregnant. Yeah, where are we? I think that's it. Is there any other question?
Hello, doctor.
Yes, hello.
I was asking, let's say I went a first C-section. Then I want to have a second kid. Will I have to go under C-section or I'll just give birth normally?
Okay, thank you for that question. So the first thing is that we always want to know, why did you undergo the first cesarean section? Okay, because as we've seen, there's so many indications. It could be something to do with the baby's heartbeat. It could be maybe the baby was not positioned well. Sometimes it could be a function of an emergency because maybe you're bleeding. So we always look to see, why did you go for the first cesarean section? And is it a reason that could repeat itself? And usually that is in the case when someone has a contracted pelvis, or now sometimes what we call the labor dystocia. You know, you've been at the same stage of labor for so long, and when you go in, you don't find anything. So usually we end up diagnosing an inadequate pelvis. So if you do not have that as an indication, then usually you can be a candidate to try for normal delivery. Okay, so you just need to be counseled on the risks of trying for normal delivery, which I think we've gone through. And if you are willing to try and you fit the profile of trying, because your baby needs to be less than 3.5 kgs in that pregnancy, you need to go into labor naturally. You should not go beyond your due dates. So by 40 weeks, you need to have gone into labor. Then you can be allowed to try for vaginal birth. But again, the thing to note is that it needs to be done in a setup whereby they can quickly do a cesarean section if there's need for that. Because sometimes the labor does not progress as you'd like it to, and you end up going for CS again. So that's what needs to be looked at. Any other questions? You're welcome.
I still have another question.
Yes, please ask.
Based on my personal experience, I wasn't diluting or dilating.
Dilating.
Yeah, from like 4 hours, I was still at 2 centimeters. Then they had to perform a C-section, and that problem still occur in another pregnancy.
So you were at 2 centimeters for 4 hours. Now, the thing is, with labor, and that's why I'm telling you, we're trying to move away from doing some of these primary cesarean sections for such indications, because 4 hours is not really an adequate period of time for you to say that you've given a lady time to progress. Because as long as you're less than 4 centimeters, you can actually be less than 4 centimeters for over 20 hours, and that is still considered normal.
I was given around 23 hours till the same. It just reached at 4 and never progressed.
Okay, and the necessary interventions were done. You were put on syntocinon or the fluid that for augmenting of labor.
Yeah.
So normally we put that for at least 12 hours to see if you'll be able to progress into labor. If that fails, then we say we have tried to augment the labor, but it's failed. So that's now something that could reoccur, because it may mean that maybe your receptors are just not responding to that hormone that is supposed to help you contract and adequately open up the cervix. Okay, so some people that may recur, in other people it does not recur. You find that maybe in the first pregnancy they went into labor well, and then in the second pregnancy you find that they were just not dilating well. And a function of dilating could also be a function of how the baby is positioned. If the baby was not positioned very well, then you find if the head is not compressing well on the cervix then does not open up. So it would be difficult to tell whether it would recur or not, but that would not be something that you would say that it's a mandatory cesarean delivery the second time.
Okay, thank you.
Yeah. Anyone else with a question? Must all multiple. I think there's one here.
I'm trying to look at the questions from the Facebook.
Hello. Yes.
I'm trying to look at questions from Facebook. For those who are joining us on Facebook, unable to see any questions. I hope we'll be able to gather questions when we have the feedback form.
Right.
But I want to allow everyone to unmute, so that if you have any question, you can unmute and speak to Daktari. Thank you so much. Thank you so much. Ivina Achieng is saying the session was very informative, Daktari. Thank you. Eunice Omwanga is saying, thank you so much, Doc. That was an insightful and well-delivered session. Thank you. Any more questions?
There's one question here that maybe I haven't answered from Eunice. She asked if all multiple pregnancies go through CS, and the answer is no. There are several patients that we've actually dealt with multiple pregnancies, and they've been able to deliver vaginally. So it's a function of how the babies are lying, and more often than not, if the first baby is lying with the head down, then that's someone who may be allowed to go through a normal vaginal delivery. However, it depends on, you also have to be counseled on the risks. And usually once counseling has been done, because usually the risk is to the second twin, especially because the first twin by and large comes out well, but sometimes the second twin can turn and you end up with a malpresentation and you're not able to get the baby out in good time. In rare cases, you can find if the first baby is now not head down, then you find that the twins can actually interlock their heads together and the babies are just not able to come out. So the answer is no, not all multiple pregnancies go through cesarean section. Yeah. Anything else? Okay. Thank you so much, Esther. You say you've learned a lot from this session. I will share the slides with Katile. Yes. I think I had also informed her that unfortunately I have another meeting in a few minutes, 7:30. So I hope in case you have any other questions, you'll be able to send them in the feedback forms, and definitely we'll see how we can address those as well. Thank you, Joyce. You say you learned a lot. Thank you.
Thank you so much, Daktari. We are aware you had a meeting from 7:30, and that's why we wanted to have the session a little bit earlier with you.
Okay.
So allow me just give 5 minutes for any more questions from the team before you leave and prepare for the next meeting.
Okay, thank you, Nancy and Peter, for your comments as well. You say you've learned a lot. Anyone else with any other questions? She asked if
Thank you, everybody. Just to remind you, please ensure you sign in the attendance form, because some people always ask me about the link after we have already finished the meeting. So I really want to ask everyone, between the 1 hour, the meeting link for attendance is always shared. Ensure you key in your details for progressive monitoring. Then secondly, we would also appreciate that we have done this session 14 and we shared in the sessions that were supposed to be done following after this one. We will appreciate Dr. Muluka. We thank you for this session. At least we are aware of the CS. We've been just hearing it about, but at least we have gotten highlights about the CS.
Okay.
Thank you.
You're very welcome. In case you have any other questions, feel free to ask. I try to keep the content specific to what I felt you may want to know, and